Good morning, good afternoon, good evening to all. I'm Dr. Kiggundu Josen, the Senior Program Officer, Differentiated Service Delivery, Ministry of Health AIDS Control Program, Uganda. I'm going to share with us one of our community models. This is the Community Client-Led at Delivery, CLAD. Okay, I'm going to look at why community DSD, the CLAD, and then management of CLAD groups, service package. We shall look at a visualization for the member visits, roles of key CLAD group actors, termination and replacement of group members, and then look at the DSD model mix, Jan and September, any challenges and any lessons learned from implementation of the CLAD. Why community-based care and treatment? We wanted to address physical barriers to access. Physical barriers like distance, difficulty travel conditions, time and cost constraints, wanted to address those constraints of working hours, travel cost, loss of income while accessing health services, long waiting times, congestion at the facility coupled with long waiting time during the clinical appointments, inadequate space for clinical care, counseling, dispensing medicine, record keeping at the facility, and limited human resources for the facility. Now, all these underpin the importance of having community-based care. Now, our recommended differentiated HIV care and treatment models. We have two models in the community. We have the CLAD and also we have the CDDPs. And we are going to look at and focus on the CLAD. Take note that only and only for stable clients. And in Uganda, all people living with HIV are eligible for differentiated care and treatment. However, the model will depend on many factors, including clinical stability. What is a CLAD? A CLAD is a platform for client groups comprising of stable clients living in the same community who use that to access art in the community. The group comprises of 3 to 6 who provide peer support to each other and alternate to pick drugs from the facility. CLADs, why CLADs? It provides an opportunity for interested people living in a given community to receive HIV treatment within the community. It empowers clients to monitor their own health and take action with the support of health workers. Provides opportunities for peer-to-peer psychosocial support and engagement in other income-generating activities. Management of the CLAD groups, CLAD group formation, there are a number of processes that we have to undertake to form. One of them is categorization to stable and unstable. Only stable recipients of care qualify to join the CLAD groups. We need to do identification, mapping, sensitization of the clients, consenting of those who are eligible, identification, and training of group leaders, harmonization of comprehensive clinical evaluation, and doing the viral load appointments. All this is what we undertake during the CLAD group formation. Now, organizing CLAD groups in the community, group members agree on a location of the group meeting and communicate it to the health worker. The health worker goes and ascertains that actually that is a suitable meeting place for the group. Group members agree on the mode of facilitation for the group member selected to pick drugs on behalf of the others. This could be through group contributions or from their savings. At the end of 3 months after the comprehensive clinical evaluation, group members hold 2 meetings. One meeting is a community clinical assessment. This is a day or 2 prior visiting the facility. And the other meeting is after picking, one member has picked the drugs, which is called the post-drug pickup meeting, where they do community delivery. The service package, we have clinical consultations, refills, lab tests, and adherence support. You look at the service package for consultations, they do clinical consultations every 6 months. And this happens at the facility by the clinicians and look at the service package of opportunistic infections, adherence, support, nutrition, and all that. Refills, 4 refills, can be in community and facility. Every 6 months, they have to go to the facility, and when they go to the facility, they get their refills at the facility. The other refills are in the community. Lab tests are not any different from any stable person. The viral loads, they usually do them at the visit when they have come all members have come at the facility. And then adherence support is done at every visit. Can be in the community, can be the clients, the peers, but also experts and counselors support that. Just to give us a visualization of how these CLAD members visit the facility. So when the group has been formed and they are ready, they come for their maiden pickup, say that's in July 2020. Then 3 months later, one member comes and represents the other members. And usually we prefer the group leader to be the person coming. They first have a meeting before the person picks, and then when the person picks, when they returns with the feedback, they provide that. Then 3 months later, all the 6 members return, and 1 month and 3 months later, another member. 3 months later, all the 6 return, and 1 month later, another member, and then just like that. So every time you have the 6, all the group members with you, that's when you do the comprehensive clinical evaluations, but also the bleeding, whatever bleeding you need. You give for viral load, those who are due. Initially, I said one of the things we do is harmonizing their bleeding rate. We very much want that the group all get bled on the same day, and we have a bleeding window that helps us harmonize that and be able to do that every time they are due. We are able to bleed them. What are the key roles? Group leader, he ensures that each group member signs the CLAD monitoring form, which is a documentation for while in the community, conduct monthly monitoring of group members, inform health workers of any issues, e.g. client missing meetings in the community, conduct group counseling, carry out clinical assessments, facilitate referrals, identify and report any adverse outcomes, but also ensure each group member undergoes clinical consultations twice a year. The group members attend clinic on their appointment date, pick drugs whenever it's their turn, sign the CLAD monitoring form to acknowledge receipt of their drugs, provide peer-to-peer adherence support, report the facility, the status of other group members, take all his or her drugs, finish the old supply before starting new, bring a bag to pick drugs whenever they are coming, and attend meetings as required. Health workers orient the CLAD group leaders, supervise the CLAD groups, track and follow up missed appointments of individuals in the group, link CLAD members to other services, e.g. family planning, cancer, breast cancer screening, provide comprehensive clinical evaluation, dispense correct drugs, review information in the CLAD form and provide any feedback where need be, transfer the information from the CLAD form to the treatment card, review list of appointments, review and file CLAD monitoring forms, and give and document the next appointment in the appointment book and the client held card. Termination. A member can be terminated or replaced within a group. When one member or more withdraws from a group due to inability or ineligibility, transfer out, death, loss to follow-up, the group can be supported to replace this person. A group member can become ineligible and will need to be referred back to the facility if one develops signs and symptoms of disease, becomes unsuppressed, becomes pregnant, misses 2 consecutive appointments or defaults on treatment, requests to exit the group. The health worker must at any moment be notified, and it's only and only the health worker to approve termination and replacement of a group member. Just to give us a model mix by end June, Jan to September, we see that our CLAD has gradually increased. By the by end of the first March quarter, we had 4.9 enrolled on CLAD. We have increased this to 5.7. It's a gradual increase. but we are moving in the right direction. Our target is to have at least 15% of all recipients of care active on ART or enrolled on CLAD groups. We have had some challenges, low literacy levels affecting ability to effectively implement and document CLADs. And during this poorly feeling CLAD monitoring is something we see and attribute to the literacy issues. The group members need to be a bit literate to be able, but specifically the group leader, because it's the group leader documents, or at least a member to be supporting the group leader to document on the CLAD monitoring form. Tools not translated in the local language, low treatment literacy amongst people living with HIV, poor documentation by both group leaders, but also health workers. What have been the lessons we have learned? Continuous sensitization, especially using clients benefiting from CLADs, helps increase uptake by addressing existing uptake barriers. Self-forming groups last longer and perform better than prescribed groups. And we encourage that we sensitize the people living with HIV and encourage them to self-form, to form their own groups. We don't want them to be prescribed. Group leader trainings are critical for effective management of CLAD groups, coupled with supervision of these groups. CLAD groups provide a strong opportunity for peer-to-peer support, issues like adherence, community TB surveillance, and we have seen that in these groups, there is very high retention and very high viral suppression. CLAD groups support facilitate to client and client to facilitate communications, which supports and ensures prompt interventions. Supervision of community meetings helps address challenges in real time. CLADs have significantly contributed to retention, adherence, and we want to do an analysis, but we have preliminarily seen that viral load suppressions in CLAD groups is very high. CLAD groups improve on viral load monitoring because of the more involvement of the clients and of the recipients of care, and therefore they request that they get their viral load because that's one of the requirements to qualify to be in the CLAD. Acknowledgement to MOH fraternity, DSD Technical Working Group, PEFA, Global Fund, IPs, the district health teams, healthcare workers, recipients of care, and other contributors. Thank you very much. If an opportunity comes up, welcome questions and comments.